So good morning and welcome to the Oklahoma Long-Term Care Immunization webinar. We are start on time and end on time kind of people, and so we're going to get started and we will adjust as we need to if anybody says that they're having problems with the technology as we go. We have two of us running this webinar. One person is going to be responding in the chat. And so if you are having any problems or difficulties, please feel free to write in the chat and we will respond and see what we need to do. I also wanted to let you all know that this webinar software, we have tried several, and this one is phenomenal, but it has about a 15-second lag on it. And so we are operating with that 15-second lag, knowing that it exists. But some of the slide transitions sometimes get a little bit funny because I can't predict the 15 seconds super well. And so know that is a software glitch more than anything. On the other hand, we love the way that this one records and we love a lot of things about it. So I will do my very best and we will go from there. So this webinar is part of the Oklahoma Civil Monetary Penalty Fund Immunization Improvement Project, and we are in our second year. And this is this is through the Oklahoma State Department of Health through the Civil Monetary Penalty Fund. And that fund is part of the fines that are levied against nursing homes are required to go back, the funds themselves are required to go back into the state and provide resources for all of you who work in long-term care. And so our job in this immunization improvement project is to understand practice and understand the way you all do your work. And we do that through calling every single home every single year and asking a bunch of questions. And we may not get in touch with everybody, but we really do try. We share best practices that we find, and this is one of those venues to be able to do that. And so we're going to talk about that a little bit as we go along. And then provide resources, education, that is this, and then root cause analysis. If you are looking at your immunizations in your home and thinking, we're not knowing exactly why we can't get to 100%, or we're at, 85% and we know we need to be much higher, we are very, very happy to meet with you virtually. We do it over the phone and walk through what that could look like with you. And the ultimate goal is to improve the care of residents. And we have seen numbers for both influenza and pneumococcal vaccine go up over the last year and a half. So who are we? My name is Andrea Frazier. I am a nurse, and I am a nurse leader who has worked in long-term care. So I love residents and I know your world. And Michael Selvage is my business partner. He has also provided leadership in long-term care. And we have been hired by OSDH to do this project. We are based out of Colorado, and we are part of this. We are so excited to be working with you all, and we love talking to you and learning about the way that you all do your work and what you do. And so I think that's all we want to talk about our company. We do a bunch of regulatory rescue and a bunch of things with state departments of health across the country. So today, our presentation, we are going to look at flu season. And we are going to have about 3 slides on coronavirus, 4 slides on coronavirus, just because of what's going on in the world. And I wanted to acknowledge what's going on in the world. We are going to look at pneumococcal recommendation changes. And I think that that's probably why the majority of you are here today, is because those recommendations changed a couple of months ago. And the question is, how in the world do we change our process to align with the new recommendations? And I'm hoping that I made it simple enough that you guys feel like you can just put that into place and just take care of it. And then the third thing is, we have been working rather hard to develop some tools for you to make that easy to implement. And so we are going to look briefly at the tools, and at the end, part of these webinars is to obtain feedback on your questions and what you all are confused about, so we can make sure that the tools address the needs that you all actually have, not just what we are making up in an office in Colorado, that these are the needs that you have, especially based on these new pneumococcal recommendations. And so These are the 4 coronavirus slides. The very first one is that on March 9th, CMS sent out a memo to state survey agency directors, and it outlines very specifically some of the changes that they're making, and they're putting surveys on hold and some other pieces like that. But they also have a huge section on revised guidance for visitation and things that you all need to be doing to screen people coming into and out of your home, and things that you guys need to be thinking about right now. And so if you have not already A, looked at this, and B, met with your team to try and figure out how to put some of these pieces into place, I think now is probably the time to do that. We want to be really thinking about environmental infection prevention, probably on several steps higher than we do for the flu every year. How do we make sure our home is as clean as it can be? And how do we make sure that everyone walking into and out of our home is as healthy as they can be at this point, and that we're not bringing virus into our home? We need to be looking at visitor and volunteer screening. We need to have a process for sick residents, and then a process for sick staff, and then staffing plans as we go along. How do we shift those based on the current reality? And that current reality is probably at the county level or at the city level, or where you are. What I did want to do is put in a couple of slides to look at who is having problems with this disease. And you'll notice here that this is people with cardiovascular disease, diabetes, chronic respiratory disease, hypertension, and cancer. And when I think of where these people are in our society, many of them are in the places where you all are working. And so that is tremendously concerning, because these are people who are having problems with this virus. We look at male to female, and our men are dying at higher rates than our women are. And so it's just something to sort of keep in mind and in the back of our heads. I don't think that we treat anyone differently, but it's kind of good to know that. And then the third piece is that our older residents are really by far having the most problems with this. And so just as we look at this, as our older residents are showing any signs and symptoms, we want to be on it ahead of time. And the best resource that you all have are your county health departments. And so both reporting of symptoms to them and reporting what's going on in your home to them, to track across your county, and then to receive guidance as to what we need to be doing as our residents start showing symptoms, or even with visitation guidelines. Our county health departments are by far our best resources in these cases. And I know, having watched in Washington State, some of this is terrifying for us as we think, what happens if this ends up in my facility? And so I don't have good answers. I don't know if anybody has good answers, aside from, as best as we can, keeping up with what is CMS telling us, what is the CDC telling us, what are our health departments telling us, and really moving forward with as much prudence as possible, saying some of the preventive actions we are taking today will save the lives of our residents over the next several weeks and months. And with that, we're going to jump into vaccines, which is why you all are here today. And it's a funny transition in why are we talking about vaccines in the midst of a national health crisis and a worldwide pandemic? And yet this is when they were scheduled, and so this is what we're going to do, and there are changes that you all need to know about. And I think when we start talking about vaccines, there are so many priorities in long-term care. The question is, why should I make vaccines a high priority, especially when we have employees who sometimes are very resistant to taking a flu shot? We have people who have misconceptions about immunizations, and they need education. And then there are facility politics of, if I require my employees to wear a mask if they are not immunized, am I going to have huge amounts of turnover over the next several months? What does that look like? And how much political will do I need to spend on vaccines and making sure my residents understand why they're important, and my employees understand why they're important, and what we need to do? And so the first piece of all of this is, when we look at our residents and our employees and their well-being and their health, there is tremendous risk to our residents in that they're the most vulnerable people in our society. From a health perspective, people don't generally move into long-term care facilities unless they need long-term care. And as such, they have comorbidities and they are at risk. But the second piece of this is that when someone has the flu or has pneumonia, even if they get over that, it's miserable in the time, but even when they get over that disease, they have quality of life sequela, and many of them have permanent quality of life sequela. And so there are two studies that I've talked about several times when we do education sessions across the state. Both of them look at ADLs. And if we have residents who end up in the hospital with pneumonia, on average, they permanently lose one ADL. And so when we think of our quality of life and we think of our residents' quality of life, those who have the highest amount of functioning generally are the ones who are doing the best. And so if we can do anything we can to keep them from getting pneumonia, we can keep them functioning for longer and we can keep them doing well for longer. In the same way, communities who have high flu in a year have statistically significant changes in their ADLs, in their MDS, that last for months and months and months. So again, what we see is a permanent decline in ADLs for people who get the flu while they're in your facilities, and that's in long-term care. And then the third piece is that there's actually new evidence that's showing that when we immunize people, regardless of if we're immunizing them for pneumococcal disease or flu or, herpes simplex, if we're trying to keep them from having shingles, that their ability to make antibodies actually improves over time and stays improved, not necessarily just for the disease that we have vaccinated them against. And so, weirdly enough, vaccinating our residents gives their body the opportunity to make antibodies, and that opportunity in many ways gives them more protection for more viruses over time than just the vaccination that we're giving them. And then when we look at our whole home health, when we have residents, when we have employees, when we've looked at our contractors and our volunteers and our visitors, and everyone who is coming into contact with our residents are immunized, they are less likely to get the flu. They're less likely to get circulating pneumonia that's going around in the community, and they're more likely to do well. And so when you hear me talk about this, you will never hear me talk about just how do we offer immunization to our residents. It's also how do we offer immunization to our employees, and how do we really think through who is in our home and how do we make sure that these people are immunized. Because when our employees are not vaccinated, they are the ones who are out in the community, and they are at their kids' schools and soccer games and in the grocery stores, and they are some of the most active people in our community that then come in and they go from room to room to room to room to room in your home. And so when they are known in the literature as super spreaders, or people who have contact with an awful lot of people in the community, and as such, it is most important that they become immunized in the whole community and in your home to protect your residents. Why residents don't get vaccinated, and in many ways why employees don't get vaccinated. They are worried about the side effects and the adverse outcomes, or that it causes the flu. They don't necessarily think it's effective, and we're going to talk about that in just a little bit. They think that vaccine components may be harmful to them, or they don't think it's necessary. And so the most recent finalized statistics that we have are from 2016 for influenza, and that has that about 63% of those 65 plus are vaccinated. So we have about a third of people who are over age 65 who are running around unvaccinated against the flu. So let's look really quickly at the vaccine requirements according to regulation and according to Oklahoma statute. And as we've talked to people, people absolutely know about the CMS regulatory regulations. They don't necessarily know about the Oklahoma statute. And this has been in play for quite a long time. They have been updated as we go along, but this is for nursing and specialized facilities. And it walks through, and I instead of you guys squinting to try and figure out what this looks like, I have made it bigger on the next slide. And so, on 2 slides up. So we have the Oklahoma statute. We have our F tag 883 that for influenza vaccine that says we have to have policies and procedures and walk through that. And then we have our pneumococcal vaccine that says here's what we need to do about pneumococcal vaccines. So Oklahoma statute and CMS regulation basically say that we need a policy that aligns, that's our policy. And the policy needs to align with the most recent ACIP or ACIP and CDC guidelines. That we need to document evidence of offering influenza vaccine to both our residents and our employees. And this comes from the Oklahoma statute. They require vaccination for our employees that we offer it. Document evidence of offering pneumococcal vaccine to all of our residents. And then if someone refuses, we have to have them sign a statement either by the resident or the resident's representative or by the resident's physician that says that we have offered it and that they are refusing it. And then the Oklahoma statute says that standing orders are allowed. And we'll talk a bit about standing orders in a little bit because I know that they come with a bit of, but we're not allowed to have standing orders. And so we're going to talk about the best way to do that. CMC immunization guidance says that we need to have a policy that we are doing education of the benefits and potential side effects of immunization for our residents, that we offer influenza vaccine and pneumococcal vaccine to all residents as is appropriate, that they have the opportunity to refuse, and that we've documented it in the medical record. And so when we look at your policy and what does your policy look like in your home, we are required to screen all of our residents as they come in and then annually screen them for immunization. So we need to know the resident age, their pertinent medical conditions, their vaccine history, and your provider preferences. And so we're going to talk about that too. But their vaccine history, we know that sometimes that is fairly easy. It comes with them from the hospital or it comes with them from their primary care physician. And sometimes it's really, really hard. What I want you to know is that you can actually call your pharmacy if this resident has insurance. And often they can look up under Medicare, Medicaid, and see if a Pneumovax or a Prevnar 13 has been billed to them. Or there's a number for the drug company that provides Prevnar 13 that you can actually call and run your resident through that phone number, and they can tell you whether or not they've had a dose because they keep track. The offering, we need to do resident and family education, we need to get appropriate consent, and we need to administer. And we'll talk about all of that too. So your to-do from this section is you need to look at your policy and your process. We need to make sure it aligns with both the Oklahoma statute and the CMS regulation, and you need to make sure that it says we are looking at the most up-to-date recommendations of ACIP and of the CDC in order to make our vaccine decisions. So flu season this year. It had the earliest start since 2009, so in a decade, and this is something they are calling a double-barreled season in that we don't have one flu virus circulating, we've got two. And so early on, we had quite a bit of flu B, and weirdly enough, that was the people that was affecting the most were our younger population who had not been around quite as long and probably had not developed antibodies to this flu B strain, which is passed from person to person. We also have a flu A strain, the H1N1, that's circulating right now. And then the other piece is we know that our flu statistics for this year are confounded by coronavirus. We don't know how much. And so we know that we're seeing some flu statistics go up that are flu-like symptoms, and we don't necessarily know how much of that is to do with coronavirus. But this is Oklahoma's most recent data from the week ending February 29th, and you will see it went up, it went down, it went up, it went down, and that's that double-barreled flu season that we talked about. But it looks like we are heading down for right now from a flu virus perspective. And we know that other things are going on, and so we may see that look a little differently. From a national perspective, these are the CDC estimates for right now, that we've had somewhere between about 34 and 49 million people have flu-like illness. That's resulted in about half of those people going to the physician or going somewhere to get that looked at. We've had about 350,000 to 620 hospitalizations and somewhere between 20,000 and 52,000 flu deaths. Now, they're saying that death number is actually lower than it has been in a lot of years, which we are grateful for. And then Oklahoma flu, these are more confirmed than estimated. So you'll see that these don't really line up super well with some of the other statistics that I just showed you, especially our death statistics. And we are grateful that right now we have less than 60 confirmed flu deaths in Oklahoma. But I wanted you to look at that against the age and realize, again, our residents are the ones that are by far the most vulnerable to flu right now and during this flu season. If you need to look at where flu is circulating and what that looks like, you want to go to the Oklahoma Flu View. This is something that is easily Googled, and it's that top result. And then you can look at it by what's going on across our state. And you guys will notice here that Tulsa County and the area right below Tulsa is what has been hit really, really hard this year with flu. And so if you are in that area, it's good to know that. And it's really good to know, it's circulating right now. And this is something that I need to make sure that we are really vigilant with our environmental controls. Flu vaccine effectiveness is actually quite good this year. They're thinking that it decreases laboratory confirmed influenza flu virus by about 40%. They're saying that flu B virus that came around was about a 60% match, and the H1N1 is virtually 100%. And so the combination of those, they really think it's been almost a 50% decrease over what it would have been if people were not vaccinated. This is a little reminder that the CDC recommends influenza vaccination while influenza viruses are circulating in the community. So they absolutely still are. And so even though we're at the end of that March 31st coming up in about 3 weeks, as long as you have influenza, as long as you have unexpired influenza vaccine, they still want you to screen and offer to your residents as long as it is still going on in your community. And so that's where that flu view is really, really helpful. We get a lot of questions about the high dose vaccine, and so I wanted to just mention that here. They have several studies out that have large sample sizes that show, quote, a significant reduction of risk for both preventing flu and then preventing hospitalizations in our older populations. In preventing flu, they think it's about a 25% reduction over people who are immunized with the regular flu vaccine. And then with hospitalizations, they looked at 38,000 residents of 823 nursing homes in 38 states, and again showed a decrease. Now that hospitalization amount is about a 0.5% difference between those who are immunized with high dose and not. And so it's still one of those things where the CDC just says, immunize your residents. It doesn't matter with what. And yet at the same time, your home may say, we think it's worth it because we may decrease by 1 or 2 hospitalizations this year. And that absolutely pays for the increase in cost. There also was a large Veterans Health Administration study that basically they said the high dose is more effective than the standard dose vaccine. And so we know that it's more effective, but how much really is up to you. It's a home by home decision. You guys can look at your facility risk and then take a resident centered approach. What makes the most sense for our residents? And I think the other piece of this is as we move forward, we are getting more evidence. And I think there will come a time when there will be a specific recommendation either for or against this by the CDC. Right now, what they say from a cost perspective is Medicare Part B, most Medicare Advantage plans, and about 85% of Medicaid plans will cover the high dose vaccine. If that's something you all want to look at, for people who are not covered, according to the vaccine website, it's about $50 a dose. If that's something that you all want to do, versus about $10 a dose or $10 or $12 a dose for that regular flu vaccine, which is recommended. Egg allergies, we have better guidance on egg allergies. And so what we know right now and what they are telling us is if someone has a history of serious reaction from the flu vaccination, we cannot be sure it's related to eggs. And so in that case, the flu vaccine is medically contraindicated for that person. We just need an order or a note in the chart that says we are not giving this to this person because they have a history of serious reaction. We don't say it's because they are allergic to eggs. Now, if someone is allergic to eggs and has had a history of hives with the flu shot, what they say is that that is not a serious reaction. And the current vaccines, even those made in eggs, are basically cleaned of their egg protein and should be okay, and they're all recommended. But at the same time, if I have someone who's nervous about it, an egg-free vaccine exists. And so there are two that are made in cells and one that is made in made from recombinant DNA. And so in those cases, what they say is we should screen and offer and do really good education to say you should not be having, this should not cause a reaction to you. And then what they say is to be prudent, make sure you have supplies to manage a serious reaction. And you should be doing that if you're administering flu shots anyway. And so that would be having an EpiPen around just to make sure that if someone has a serious reaction, we're able to manage this. And so the good news is if I have someone who is allergic to eggs in my facility, we probably want to look at, do we order in one dose of egg-free vaccine for them? Or are they comfortable knowing that we're removing the egg protein from vaccines and they're still willing to take it? And I think as with anything, we want to look at a resident-centered approach in those cases. But that's something that I still hear about when I call, and so I wanted to mention it. So now we're getting to the pneumonia vaccine changes and those recommendations that changed at the end of last year and early this year. The last recommendations were made in 2014, and what they said is that anyone age 65 plus should have both a Pneumovax 23 vaccine and a Prevnar 13 vaccine, and they are given a year apart. But they said they would revisit it in 2018. And so 2018 passed and we saw nothing, and 2019 almost passed. And I kept checking on it and it just wasn't coming. And at the end of 2019, they published new recommendations. What we need to know, though, is that new pneumonia vaccines are coming out across the world right now. And I think that this is only the beginning in changing those recommendations. And so we're going to have to keep on our toes over the next few years to say, what are the new recommendations as new evidence comes out? And I have a feeling that this is just going to be a moving target for quite a little while. So what we have done over the last 2 years is we have tried to make this as simple as it possibly could be for our residents over age 65. And then we would send people in places to go and get things for our residents that are under age 65. And what we need to know is that is no longer the case. And so if you have this sheet and you are using it, we need to just throw it out because this is no longer what's recommended. And know that we are creating additional resources, and based on your questions, we're going to tweak those resources and get them out to you next week, we think, to be able to say, okay, this is what my policy needs to look like, this is what our process needs to look like. But there are 3 different things for our residents that we want to look at. The first is that there are places where both Prevnar 13 and Pneumovax 13 or Pneumovax 23 are recommended for all of our residents, regardless of their age. And so if there are 2 places there are three places where what this looks like. On the other hand, that certain medical conditions, it's like, oh goodness, how do we manage this? So if you have a resident with cochlear implants, they need both Prevnar 13 and Pneumovax 23. If you have a resident who has a cerebrospinal fluid leak, they need both of these. And then there is a list of certain medical conditions, which could we be any more vague? The good news is we have a list of certain medical conditions. And know that this presentation will be available to you, and we have this list as a part of the resources that we're sending out. But those certain medical conditions are generally people who have immunocompromising conditions, and this is the list of, I believe there are 10 of them that they want us to look at and to screen for. And so in our screening tool, we have, does this resident have any of these things? And if you check it off, then we know that we're supposed to give both the Prevnar and the Pneumovax 23, regardless of age, to these residents. Pneumovax 23 only, and it is recommended for residents aged 19 through 64 based on their risk. And what we can do for anyone who is less than age 65, they can get up to 2 Pneumovax 23 vaccines 5 years apart. They are based on risk factors and their exposure. So the first is anyone who smokes cigarettes, it is recommended that they get those 2 Pneumovax 23 administrations 5 years apart below the age of 65. And then adults who have additional medical conditions. So are additional medical conditions the same as certain medical conditions? And the answer is no, they are not. So the additional medical conditions that people may have are alcoholism, chronic heart disease, chronic liver disease, lung disease, or diabetes. And these people should have a dose or 2 doses of the Pneumovax 23 before the age of 65 if they are in your facility before the age of 65. Now, anyone that age 65 and plus should have 1 dose of Pneumovax 23 and they are fully vaccinated. So even if they have those conditions, if you have someone who's 66 or 67 who comes into your home who is a smoker or who has heart disease, they just need 1 dose of the Pneumovax 23 that's recommended for them. They don't need that second dose, and you don't need to keep track of them for every 5 years. So here is where the waters got complicated. So instead of saying everyone age 65 plus needs a dose of Prevnar 13, what they have now said is that we should use shared medical decision making in order to make decisions about Prevnar 13 for anyone who is age 65 plus. So those people in that first section that are recommended to have both Prevnar and Pneumovax, though that is recommended, we go in and say these are recommended for you. Anyone over the age of 65 who does not have that, then we have some decisions to make. And the pre-work is the first thing that we're supposed to do is assess our facility and our community risk. And so they recommend the Prevnar 13 for our pediatric population. And what they've realized is that as we have good coverage of our pediatric population in specific communities, it decreases the risk for everyone, and it decreases the circulating viruses that are covered by Prevnar 13. And so you want to go to the Child VaxView Interactive, which is a link on the CDC website, and look at your specific area to be able to say, what do I do, and what are the circulating viruses that we have in our community? And I see to the right, someone is asking if we have slides available to us after the webinar, and they are absolutely available to you, as are tools that are going to have all of these links in them, and you can just kind of go from one place to another and say, this is the pre-work I need to do, this is what I need to do. So this is not the only time you get to see them, and you can stop frantically writing things down if you are doing that. So the second thing we want to do is assess the specific resident risk. And this is both the specific resident and resident risk in your facility. So ACIP and CDC have indicated long-term care populations may have a greater than average benefit from that Prevnar 13 vaccination. On the other hand, they did not recommend that all long-term care residents get it. And so this is where you need to talk to your medical director and say, are we better? And if you are an infection preventionist, you also want to talk to your leadership in your home and say, are we being prudent? And are we making sure, like, are we going to offer this to all of our long-term care residents because of this greater than average benefit? And then we want to look at other underlying medical conditions that people may have and say, in this case, we want to recommend this for this person. The other thing we want to think about is our short stay resident versus long-term care. So it used to be that someone would have knee surgery, they would have no pre-existing conditions, nothing chronic, and yet they're age 66, and so they are recommended to have the Prevnar 13. That is not necessarily the case anymore. And for many of you all looking at it and saying it doesn't make sense to spend this much money on a short stay resident who may leave in a week or two, this is something where you guys may say it isn't recommended for this population in our home to have that. And we can have a discussion about that. And your short stay metrics may actually improve significantly based on this. We want to look at resident risk and comorbidities in their condition. And then what they keep saying in these recommendations is that it is based on the resident and decision maker preference. People who want to receive the Pneumovax 23 only, or people who want to receive both the Prevnar 13 and the Pneumovax. And so what we're doing is we're looking at what is the risk of our home, what is the risk to this resident, and what is our recommendation, and have a discussion with our resident, with their decision maker, and say, these are your risks, this is what we know, and what do you want to do? If they just want the recommended Prevnar or Pneumovax 23, we screen and administer and document. And in that case, they are up to date if that is what they want. If they want both of them, then we go through and we administer both. But what we also need to know is that if a resident has received one dose of Prevnar 13 and one dose of Pneumovax 23 after the age of 65, they are fully vaccinated against pneumococcal disease, and we do not have to revisit this for the rest of their lives. No additional doses of pneumococcal vaccine are needed. So administration, if someone is supposed to get both or has chosen to get both, we start with Prevnar 13. In 1 year, we administer a dose of Pneumovax 23. If someone is immunocompromised, your provider may say, we only want to separate those out 8 weeks. And in those cases, it is acceptable as long as we have a provider order for it. If we have Pneumovax 23, multiple doses must be 5 years apart. And if someone comes in having already had the Pneumovax 23 dose after the age of 65, but they want the Prevnar 13 dose, as long as it's been a year, you can administer it. Contraindications. Anyone who has ever had a severe allergic reaction after a previous dose of Prevnar, either the Prevnar 7, the Prevnar 10, or the Prevnar 13, or any vaccine containing diphtheria toxoid should not have Prevnar 13. And anyone who has ever had a severe allergic reaction after a previous dose of Pneumovax 23 or has a severe allergy to any component of the vaccine should not have that. And again, we need orders at that point, and we'll talk about orders in just a minute. Clinicians may administer pneumococcal vaccines if the provider, and it also says the parent, and this is for all of them, this is guidance for kids and adults or whatever, deems the benefits of the vaccination outweighs the risk to a person who has moderate or severe acute illness with or without fever. So if someone comes into you sick, we want to talk to the provider about it, but we still can administer the vaccine. And now we're heading into our final section, and that's our metrics. And so as we have talked to lots and lots of homes, we've done a practice analysis and asked you all, how do you do your work? Or we've done root cause analysis with homes that are struggling. Here's what we've found. Why we don't offer immunization to our residents. The first is that many of you are having difficulty finding immunization history. And so I talked briefly about how you can use your pharmacy as a bit of a resource for you, especially with those Pneumovax pieces. And also in those cases, MDS is very clear. If we cannot find clear vaccination history on someone, we go ahead and screen and offer, and it is far more risky for them not to be immunized than it is for them to be immunized more than once. This is a person-dependent process. So when we have homes that really struggle, or all of a sudden we see their metrics tank, Often it's a lack of a structured system, and so they had had a person who was doing it, and they're in the midst of turnover, or they're in the midst of something that's changing in their home. And if that person stops doing the screening and offering, then we see their metrics go down. And then we also see a lack of understanding of the recommendations. I know that those pneumococcal vaccine recommendations are unbelievably confusing. And as such, when we don't understand them, sometimes we don't do well with them. Short stay residents have always been an issue. And so actually, I'm optimistic that some of these new Prevnar pieces will allow you all to say this person, it doesn't make sense for them to have Prevnar, and they already have their Pneumovax 23, and I can code them in MDS as up to date. There is MDS documentation confusion. We're about to talk about that. We've had a lot of people who say, we just can't get our metrics up. We have so many people who will refuse. They just don't want it. Or we have psychiatric residents who refuse everything. And in those cases, as long as it's documented correctly, it should not be counted against you in your metrics. Medical contraindication, again, we need it documented. And then with those two pneumococcal vaccines, in between vaccinations, we've had homes that are documenting that people are not up to date. If they are as up to date as if a resident is as up to date as they can be, we can document that they are up to date, even if they are waiting an additional vaccine that's coming in 6 or 8 months. And then the last is EHR complexity, especially as we've gone live with our electronic health records. Sometimes those things don't flow the way that they should be, and we're getting people who we see their numbers just tank because they don't have that EHR up and running the way it's supposed to, and it's not pulling correctly into their MDS assessments. So when we look at influenza assessment, I know that it's tiny, so I wrote it out down below. Is the resident's influenza vaccination up to date? It's a yes or a no, and if it's not, we want to know the reason. So if it is, we need the date it was received, and you complete that and you move on. If it is not, we have a not in the facility, and in that case, no documentation is needed. If they have already received it, we need it in the medical record somewhere where that you all have done the screening, and we have the date and facility that it was given if we can. If it's a contraindication, I need either in the medical history or the provider order that it's medically contraindicated. If it's offered and declined, that Oklahoma statute says that we need them to sign a statement that says that they have declined. Not offered, you'll notice that this is red. This will count against you on your metrics. And then the inability to obtain influenza vaccine, and it also says due to a declared shortage, we need documentation of that shortage. So if you can't get your vaccines, we just need you to go online to the CDC or whoever has declared that shortage, print that up and have that in your documentation. And then none of the above. If none of those fit, that also can count against you. And so you really want to do your best to make sure that you have fit someone into those reasons and that you have backup documentation. Our pneumococcal assessment, it says, is it up to date again? Yes, and we move on. If it's not, then we want to look at the reason. And we only have 3 reasons for pneumococcal vaccine. The first is that they're not eligible, either due to medical contraindication or something else, offered and declined, or not offered. So for anyone, if we screen and decide that someone does not need the vaccine, they are up to date. So if someone is under the age of 65, your home has said, we don't believe that being in our home is is enough of a risk factor to give it, we can absolutely document that person is up to date. And they are also not eligible at this point because they aren't supposed to be having it. But what we want to do is actually document that person is up to date. Not eligible is due to medical contraindication. You want to document not eligible. There's offered and declined. Again, I need that signed statement. And not offered is the only thing that will affect your metrics. This is, I put it from the MDS manual. If a resident has received 1 or more pneumococcal vaccinations and is indicated to get an additional one but is not yet eligible, go ahead and document that they are up to date. So we have new tools coming for you. We have a facility assessment for you all to use in your QAPI to say, have I had the right discussions with my medical director? Have we made the decisions that we need to make about circulating pneumococcal viruses? What are we going to offer? What does this look like in our facility for residents under the age of 65? What does it look in our facility for residents over the age of 65? They are going to be available at our website, and you go to our website, you go to project links and immunization improvement project resources. Now, what we decided before this webinar is we are going to proactively, we have all of your email addresses. And so we will go through, and when these are up and available officially based on these 2 webinars and what you guys ask, we will send you out an email to say these are up and you can go in and look at them and they're ready to go. We are looking at that home assessment. What systems do we have? What do we need? And what are our next steps? And then a resident assessment, we have a flow chart for influenza vaccine and a flow chart for pneumococcal vaccine to look at what are our medical condition and our documentation requirements as we go along. So this is a picture of our influenza vaccine screening that, has the resident already had the flu shot this season? Yes or no? Here's where we go. Is the resident, have they had a serious reaction? Have they had this? Have they had not? Have they had other things? And so you're going to go through this, and at the bottom it says, is this recommended for this person? Is this not? And so you guys can either put this in your EHR somehow or have it as a paper in your paper chart or whatever it is you need to do, but you can use it as a tool if you would like to be able to really go through and say, are we doing an appropriate resident screening? Our QAPI assessment looks at your policy, the medical director conversation you need to have, the influenza vaccine process, the pneumococcal vaccine process, the orders you need to have, and then employee immunization. So when I said standing orders, some of you guys cringed. I could see it from Colorado to Oklahoma that you said, oh, but we're not allowed to have standing orders for people, even though that Oklahoma statute says that we can. CMS generally says that we cannot. And so what we call them is generally admission orders or automatic orders, in that they are an order that your physicians or your providers look at upon admission to your facility and say, is this appropriate for this resident? And so that's that resident-centered care piece where we have someone checking off that it's there, but what we want is for it to be as a part of those admission orders and a part of everyone's orders to say we've addressed this, yes or no, for every resident. And then the last piece is, do we have our employee immunization up to snuff for that Oklahoma statute? And are we doing this the way that we need to? And then additional resources available to you from Apiari. So we do root cause analysis with homes across the state. Many of you guys may have already done this with us. We try to tailor it to whatever it is that you need. So it may be the director of nursing, the infection preventionist, and the MDS nurse on the phone. It may be one person who this is their thing. Or it may be a whole team where you guys sit down and say, what's going on with our metrics or what's going on with our process? We need a little bit of help. Feel free to reach out to us if that would be helpful to you. We have resources on our website, everything from marketing for your employee vaccination to now we are going to have these flow sheets available to you. Email support, feel free to email us with specific questions that you have. That's why we're here. That's why the Oklahoma State Department of Health hired us. And then we have the recorded webinar that'll be available for the next month, and those slides will be available to you. And so if you guys want someone else to come in and see this, we are going to have it up. We'll put it on as a YouTube link, and you all can either watch this, and then we'll have the slides available too. And so we are going to open this up for questions for you all. And as you have questions, please put them in the chat and we will respond to them and for the next 13 minutes until 10 o'clock. And if you have additional questions, I don't know if we're going to get off in 3 minutes or if we're going to get off in 13 minutes. If you have additional questions, please feel free to email us. But I do want to start by saying thank you. First of all, for coming, and second of all, for your leadership in keeping people safe. We know that you all are at the front lines of keeping your residents safe, and that's a huge responsibility. But I also am so grateful for the way that you take care of your staff and for the way you take care of residents. And so know that we appreciate you and we appreciate the work that you do every single day when you walk into your facility. And I know that sometimes it feels like people don't recognize that. And so I want you to know that if nothing else, there is a company in Colorado who knows the work that you are doing and sees the work that you are doing and appreciates it. So I'm going to open it up for questions, and we'll do that in the chat. And then we'll move on from there. Does anybody have any questions? So I'm hearing that what is the best way to find a record of a resident's flu vaccinations? And know that I'm on delay, and so this will come in about 15 seconds, and so we'll respond to it as best as we can. Some homes have a great way of doing this, in that if you are in a rural area and have just a couple of providers or have just one hospital that is feeding into your facility, it becomes an awful lot easier to be able to do that. And what I can tell you, and the best way, first of all, is to ask the resident and their families if they have gotten that flu vaccination in the last couple of years. There is a nationwide way to document, and yet we aren't seeing it highly used. On the other hand, you can check that. And then the third is to try and figure out who is this resident's provider, and call the resident provider, talk to the hospital that they came from if they came out of a hospital, and really just sort of do that follow-up as we go. What we've told people too is if you are struggling with a specific hospital where it feels like, we have 4 hospitals that feed into our home, and one of these hospitals, we really have a terrible time getting this information. In those cases, it might be worth making a phone call and setting up a 15-minute conversation with someone in leadership at that hospital, either their med-surg director or something else. In those cases, it might be worth sitting down and saying, we're having a terrible time. Can we come up with a process? Because that sit down and that work ahead could save you hours and hours and hours into the future if that's what you find yourself doing. And so I know that's really, it's not satisfying. It's not like I can call, the pharmaceutical company who created that. The problem is there are too many influenza vaccines to be able to do that. Your pharmacy may also, though, be able to help you if this person has insurance to see if something's been billed. And again, MDS says if you've done your due diligence and no one knows, the resident can't tell you, their family can't tell you, and their providers can't tell you, go ahead and screen and offer. It's better for them to have a second vaccine than not. And so Angel says, will there be a toolkit to revamp the vaccination policy and procedure for my facility that we already have in place? And so, yes, so that QAPI toolkit that I talked about at the end, one of the very first things it says on there is, here's what my policy needs, here are the elements that my policy needs to have to make sure that I'm compliant. And so you'll basically in your policy now say, we are following ACIP and CDC requirements. We check on these twice per year, however often you're doing that. And that keeps your policy evergreen as things change. And then you'll say, we are making sure that people have consent. We are making sure people have education. We are making sure people have the opportunity to refuse, just like those your CMS guidance tells you that you need to do. And so we'll have a checklist to say, does your policy have all of these things? And if so, it should be absolutely compliant with both the Oklahoma statute and the CMS requirements. Any other questions? So I am going to stay on for the next 7 minutes until 10 o'clock. If someone does have questions, I will sit here and respond. And for everyone else, if you have questions or if you get out of here in an hour and think, oh, I should have asked that, I'm going to put up our website one more time and our email one more time here. Please feel free to email us. Please feel free to look on our website. And I'll just hang out here. But for everyone else, thank you so much for your attendance and thank you for your time this morning, and we appreciate it. So I have a question. If the resident decision maker can make a decision to not take the Prevnar 13 and just take the 23, the Pneumovax 23. And that really is what that new recommendation says for people over the age of 65. Under the age of 65, the recommendation is if you have the cochlear implants, the cerebrospinal fluid leak, or if you have immunocompromising conditions, it is indeed recommended. And of course, they can always decide that they don't want it. On the other hand, if someone just says, I am over the age of 65 and this is basically optional at this point, we want to talk to them about their risk factors. We want to talk to them about the risk factors of living in long-term care, but they can also just say, at this point, the only vaccine that is concretely recommended for me is that Pneumovax 23, and so that is the only one that I want to take. And at that point, we administer it to them, we document their decision in the medical record, and you can call them up to date.